All right, lovely. Okay, so thank you for joining. Uh, it's actually been really good that so our last session we had 70 people join, and that's really good. So I've been talking with the trustees, and if this is stuff that you're interested in, Paediatrics is the trustees are actually willing to pay for the proper subscription so we can go for longer than 40 minutes. So keep joining in these sessions, because the more teaching we do, the more likely is that we can expand the amount of teachers and the more sessions we can put on. So just out of interest, do you guys know when your finals are going to be? Okay, start of September. All right. So is this something that you'd want during the summer then? Yeah. All right. So yeah. So obviously it's in early stages at the moment. So I just bear with me. I've been getting to grips with Zoom over the past couple of weeks. But this is something that we could maybe arrange to keep going, especially over the summer, just to support you guys while you preparing for your finals. Right, so we're going to do Paediatric Respiratory Emergencies, and this is going to be recorded, so it'll be put up onto our YouTube channel. I was just going to do normal Paediatric Respiratory for finals, but as I was going through it, there's a lot of information to cover, so I thought I'd just condense it down into Respiratory Emergencies, which are quite often the things that crop up in finals. They quite like emergency management, because when you're obviously qualifying as F1, they want you to be able to just get these quick management, especially in emergency scenarios. So we are going to cover bronchiolitis, croup, epiglottitis, and then we're going to touch on viral-induced wheeze versus asthma. And then at the end, I've made a Kahoot quiz, so we can go through that at the end as well. All right. So you are in an emergency department, we're on a pediatric ward, and someone, a kid has come in, say like a 2-year-old. What are the signs of respiratory distress? Because I thought this would be really important just to get out of the way before we start going into different cases. So put on the chat, what are the different signs of respiratory distress? Yeah, so nasal flaring, good. Yeah, tracheal cut, tracheal tug, recession. Yeah, so there's different types of recession. Do we know the different types? Yeah, so subcostal recession and intercostal recession, perfect. Subcostal, yeah, brilliant. Okay, so on this slide, it hasn't actually put the medical terms. I think it's just actually describing it, which I think is probably a bit more useful. So yeah, so nasal flaring, that's normally tends to be in younger kids rather than older kids. And same as head bobbing, that's more for younger kids. Of course, you might hear stridor, so breathing sounds there. Rest rate might be increased. You might see some cyanosis. And then when it comes to the chest, you'll have intercostal recession, so that's drawing in between the ribs, and you've got subcostal recession, which is like just underneath the diaphragm. You'll get sucking around the stomach, and that's especially for little kids because they're tummy breathers rather than breathing from the chest. Just to mention, central cyanosis and tracheal tug are quite late signs. So if you see those, that is something that you should really start to be worrying about. All right, so bronchiolitis. So I'm not really going to tell you how to suck eggs because I'm guessing most people know what bronchiolitis is, but I think it's what's quite useful, especially for finals, is knowing what to look out for in histories, the management for different types of severity of bronchiolitis. So I've just put some key facts on the slide, but what I'm more interested in, so what would you be looking for when taking a history for bronchiolitis? If you suspect that, say you've got a 1-year-old coming in and mum says he's been breathing a bit faster and he's not really feeding, what are the core things you want to get in that history? And if people want to unmute their mics as well, I'm happy for. But yeah, so how long for? That's a really good answer. Feeding difficulties, fluid intake. Yeah, great. Wet nappies, perfect. Yeah, cough. Yeah, so we'll start with how long for. So how long for is a really good question, because bronchiolitis, we say that bronchiolitis gets worse on day 5. So if you've got a baby coming in on day 3, and they look pretty poorly, you know that they're probably going to have to be admitted to hospital because it's going to get worse, because bronchiolitis tends to get worse on day 5. Fluid intakes, yeah, that's a really good question. So you want to be quantifying how much fluid they normally take and then comparing that to how much they have taken today. And the problem with bronchiolitis is that because bronchiolitis, the babies tend to be really chrysally, have loads of snot in their nose and stuff. When they're breastfeeding or when they're feeding from a bottle, they're unable to breathe, and that's why they really struggle to take in fluid. So yeah, and then counter to fluid intake, wet nappies. So again, you want to quantify how many wet nappies they normally have, and then see how many wet nappies they've had on the day of admission. And we worry if a child has had a 50% reduction in the amount of wet nappies that they've had. Yeah, and cough. Cough is quite a generalized symptom, but it's sort of worth noting how long they might have been coughing for, and just in case the cough might be, they're just thinking of other differentials, so even if it might not be bronchiolitis, it could be something like pneumonia or something else that we might be a bit worried about. So the key facts you want to know about bronchiolitis is it's caused by RSV. The majority of them are caused by RSV. And the majority of cases are mild and self-limiting. So most kids that you'll see in an emergency department or in emergency department or in GP, they'll be able to go home and they'll be fine. The key signs of bronchiolitis is obviously the respiratory distress that we've gone over, and they're most likely they're going to be under the age of 2. By the age of 3, most kids' bronchioles have got to a size where they're not going to get plugged up by mucus, and so they're very unlikely to get bronchiolitis. So that's why it's normally kids around the age of between, like, obviously under 1 it can be quite severe, but we normally see bronchiolitis between the ages of 1 and 2. Just of note, it's worth also asking in the history that if there's any smokers in the house, because they did a study in Alderhay, and 70% of the kids in ITU the one thing they had in common was that there was a smoker in the house. Right. So management of bronchiolitis. So I've taken this straight actually from Warrington's emergency department's guidelines, and we separate bronchiolitis into minimal, mild to moderate, and moderate to severe. So these will, this is quite self-explanatory. So these are the things that we're looking for in children. We're happy with SATs above 92. Children can compensate a lot better than adults, and SATs above 92 are normally fine. So if we've got mild bronchiolitis, advice to parents are small frequent feeds, return if they get worse, explain that the bronchiolitis might get worse on day 5, etc., etc. It's the mild to moderate that we, it's more, the management for bronchiolitis is going to be, it's more aimed at being symptomatic. There's no real treatment for bronchiolitis. You just have to let it do its, proceed with its course. So the main, for moderate and severe bronchiolitis, we're looking for maybe supporting that breathing. So there's things that we can do. So we can use CPAP, or we can do, you can get these, I forgot the name of it now, but basically a nasal cannula that produces high pressure, and that can be a way to support the baby's breathing. But ultimately, if we're thinking of moderate to severe bronchiolitis, they're going to have to come into hospital. And it's just, as I mentioned before, even if you think it's mild bronchiolitis, you need to be thinking of the risk factors. If these, if the family lives about 40 minutes away from the nearest hospital GP, and they're unlikely to be able to get to the hospital quickly, it's always worth maybe thinking about, should that mild bronchiolitis maybe come in just to be on the safe side, because they might not be able to get to the hospital if they need to. All right, is there any questions on bronchiolitis? And this is unfortunately going to be really quick because I've only got 40 minutes. Any questions? No, awesome. Right, Croup. So again, quick facts. What's the most likely causative virus of Croup? Yeah, perfect. Parainfluenza, straight away. So this is basically an infection around the larynx. You're going to get loads of edema and swelling around the larynx, and that is why you get a barking cough. It's upper airway infection, and it's going to cause what you until you've heard it, like, you won't know what it sounds like. But when a kid comes in with the stridor from Croup, it's really obvious. When it says careful history and physical examination, so the problem with Croup is that it's very difficult. It can be quite difficult to differentiate it from epiglottitis. We'll go on to epiglottitis in a second. But one of the things that you need to be careful with any child with stridor is that you shouldn't be examining the throat. So you keep them calm. Don't agitate them. So even if the child doesn't want you anywhere near them, like, just stay away, because you don't want them beginning to cry. That like possibly obstruct that compromised airway. So in Warrington and to answer most hospitals, in our emergency department, we use the Wesley modified Croup score. I've never seen a question come up on it, but it might. They love their scoring systems in final exam questions. So it's quite self-explanatory. So stridor, so with agitation, it's more if the child was crying or if they were running around and then they were getting a stridor. So when they're exerting themselves, that's what it means with agitation. And as you can see, recession, so mild, moderate, severe. Air entry is when you're listening to the chest, and then cyanosis. And it was noticed, but with cyanosis and conscious level, the points that you get rise quite dramatically, because cyanosis and conscious level are quite late signs of hypoxia. So if we've got a child that has got any cyanosis or any reduced consciousness, that's a big red flag, and we need to be sorting that sooner rather than later. So again, there's a lot of words on the slide, so I will put up the slide so you can read it in your own time, but it's just worth going through. So mild Croup, just simple dose of dexamethasone. We like to give dexamethasone rather than prednisolone because dexamethasone is longer lasting. That's why if you give prednisolone, you normally have to give a second dose. And then once they've had their dex, we normally monitor them in the department for an hour, see if their Croup scores improved. And if their Croup scores improve, we just send them home. And then with moderate and severe Croup, this is when you've given some dex and you've only got a little bit of improvement or no improvement at all. That's when you want to start to maybe thinking about admitting them. So worst case scenario in Croup is that they fully obstruct their airway and they need intubation. So if you've got a child that you are really worried about in this stridor, so if the stridor was initially really loud and it seems to be getting quieter, that's actually quite a bad sign because it means that the airway could be getting smaller. So that will be at the point where you want to be calling the anaesthetist. The other thing that we can do with Croup is we can give them adrenaline. So you can give that as a nebulized adrenaline. And that can work, and that can improve their Croup score quite a lot. But if you're really having to turn to nebulized adrenaline, you're thinking about admitting them and keeping them in for observation. Any questions regarding Croup? Yeah, just give me an okay on the chat if you're happy for me to move on. Awesome. Yeah, these are fairly straightforward cases. It's just worth going over, and I hope everything is making sense at the moment. Right. So epiglottitis. So epiglottitis is your differential for any child with stridor. It needs to be in the back of your mind, because epiglottitis is an airway emergency. So as opposed to Croup, epiglottitis is a bacterial infection of the epiglottis. So it's going to cause swelling and edema, and this child is going to look really sick. So I think this is quite a nice picture. I don't like the mnemonic air raid, but I think it's a nice picture that it explains what's going to be going on. And really, if you suspect epiglottitis, obviously you're going to do your A to E assessment, but you really need to be getting that anaesthetist down sooner rather than later. You don't really want to be examining this child that much, because this airway could obstruct at any point. So even listening to their chest or disturb them really could just push them over the edge, and you don't want them to be crying. So the best thing to do with epiglottitis is just keep them calm, sit them on the parent's lap, and literally just wait for the anaesthetist, and they're the ones that will rule out epiglottitis. So does anyone know the management for epiglottitis? So IV antibiotics. Does anyone know what? IV antibiotics support the airway. Perfect. So this child is most likely going to be intubated sooner rather than later if epiglottitis is suspected. So they'll secure that airway, and then they will start IV antibiotics straight away, because it's a bacterial infection. So most likely, especially with peds, it'll be ceftriaxone. And the dose of that will be based on the weight of the patient. So this is a nice ABCDE approach to stridor. And as you can see at the top, any suspicions of imminent airway obstruction, you need to be calling the Paediatric Intensive Care Unit, ENT, anesthetics, etc., etc. And it's interesting. So if they say they seem to be in respiratory distress, what you can do is you can give high flow oxygen by a face mask, but just give it, waft it around the patient. You don't really want to be disturbing the patient and putting it on their face if they don't want to, because that again could make them cry. Okay. Awesome. That seemed really quick. Was there any questions on epiglottitis? Good question. I knew I should have looked that up. Yeah, there you go. They have people like you know the answer better than me. The main thing to remember that it's a bacterial infection, so it's not gonna it's gonna need IV antibiotics. It's not gonna respond well to oral antibiotics. It's a really serious infection that needs IV antibiotics. Okay, so last thing that I'm briefly going to cover, and then we'll get on with the Kahoot quiz, because I think the Kahoot quiz is going to, we'll just be able to go through some important things. I'm sorry that this seems quick, but I want to make sure that you get as much as you can in the time that we have. So viral-induced wheeze versus asthma. So this is a bit of a grey area. So a lot of the time you'll see in GP and in emergency departments, you'll get a child, say around the age of 3. See, we're running out of time. We'll get a child between the age of like 3 and 4, and you'll listen to their chest, and they'll be wheezy. But if you look at this graph, there are different causes of having a wheeze, especially at that age. And so we're very reluctant to diagnose children with asthma really under the age of 6 or under the age of 5, because we can get what these like transient early wheezes and non-atypic wheezes, which are different from the wheeze that you get in an asthma. So the wheeze in the asthma is IgE mediated, whereas the non-atopic wheezes is just that you've got reactive airways. And transient early wheezes, they are just idiopathically wheezing. There's no like direct cause. So, but even though you can't diagnose asthma, any child that comes in with a severe enough wheeze where they are respiratory compromised, it's exactly the same management as asthma. So I'm just going to go to this. So again, a lot of information, but I'd have a look at this in your own time, because it really splits up the different types of asthma not quite nicely. Now, I'm aware that Zoom is telling me that I've only got 8 minutes left of this talk, so we'll just quickly go through this. So with mild, moderate, and even with severe, the best treatment for any child with saturations over 92% is using a spacer. So even in the emergency department, we will use a spacer because they actually get more salbutamol through the spacer. And the reason for that is because you use a spacer, and the child can get if they're old enough, they can get their mouth around the end of the spacer, or they can use that mask that fits quite snugly onto their face, and they'll get 100% of the salbutamol that you're puffing into that spacer. But you'll find that the parents quite a lot of the time want them to have the nebulizer, because it makes a lot of noise and there's lots of things going on, and parents get quite reassured that they think something's working. But what tends to happen with nebulizers is that the patient doesn't tend to take in that much of the salbutamol. It tends to end up going into the rest of like the environment around the child, and normally like inhaled by the nurse trying to administer the nebulizer. This is why we only leave nebulized salbutamol for any child under who's respiratory compromised and they've got their sats under 92%. And then after salbutamol, you are thinking of getting IV access and getting some hydrocortisone into the child, and you then start thinking about ipratropium, and we do something called back-to-back nebs. So we do nebulized salbutamol with oxygen and ipratropium, and we do that 3 times, and we see if the symptoms improve. If the symptoms do start to improve, we can then think about maybe discharging the patient home with red flag safety netting. However, if they aren't improving, that's when we look to admit, and they might need some further treatment up on the Peds ward. I'm really sorry that was quick. I'm trying to give like nice little nuggets for finals, but I'm conscious that we probably should move on to the Kahoot. So has everyone got Kahoot? Yeah, so if you all know how to work Kahoot, I'm just going to change my screen share. Awesome. Okay, so have a look at the chat, see if there's any. Okay, yeah, so as we mentioned before, so there's two different types of recession. There's subcostal and there's intercostal. So I don't know if you saw on that baby, but it was more in between the ribs. And so that's something that we call intercostal recession. So yeah, 20 you got that, awesome. I can get the picture up actually, there you go. Yeah, so you've got nice intercostal recession. So subcostal recession will be more underneath the diaphragm over there. Okay, next question. Yeah, so awesome. Yeah, so most of you got that. So yeah, respiratory syncytial virus is the most common cause of bronchiolitis. So on the wards, they will do tests for RSV because it's normally the most severe type of bronchiolitis as well, unfortunately. So yeah, it's the most common cause of bronchiolitis, and by the age of 3, about 99%, nearly 100% of children will have had RSV at some point. So yeah, so by the age of 3, 100% of them will have it. Great. Yeah, so what is an indication for a hospital admission in bronchiolitis? Yeah, so nice. Yeah. So yeah, there's a bit of a couple of red herrings in this question. So SATS 94, SATS 94 in an adult we might be a little bit worried about, but in children it's more 92, SATS of 92 that we start to get a bit worried. Feeding for only 5 minutes at a time is fine. They're still feeding, and we're happy that they're feeding. It's if they weren't feeding at all that we'd maybe start to worry. Blanching rash on the leg. So bronchiolitis is caused by a virus, and so they're quite likely to actually have a blanching rash. Blanching rash is most of the time fine. It's non-blanching rashes that we get worried about. So yeah, so the answer on day 3 lives 40 minutes from the nearest hospital. So it's just what I was saying earlier, that even if they've got quite mild bronchiolitis on day 3, if they live miles away, you know that bronchiolitis can get worse on day 5. So this could be this is probably the most likely reason out of all of them that they would get admitted, just because they're so far away from the hospital. Great. Move on. All right. So the blank modified Croup score is used to assess severity in Croup. Yeah, perfect. Yeah. So yeah, it's the Wesley Croup score. Don't know if that's ever going to come up on finals, but it might just be that little nugget of information that's worth knowing. It could get you a mark in the exam. All right, question 5. So 3-year-old presents with stridor. What is your initial management? Yeah, perfect. Yeah, I thought that would be quite an easy one. Yeah, so yeah, you're not examining the throat. That's a really bad idea. it's not a bad idea to maybe form some routine observations, but obviously the first thing you want to get out of the way is your AT assessment, and make sure that that stridor isn't an airway compromise, and alert the anaesthetist if you are suspecting an airway compromise. Perfect. All right, last question. No, second to last question. So what is the feature of a severe asthma attack in a 3-year-old? Yeah, so I think I worded this in maybe like I tried to word it in a way that they might word it in finals. So yeah, so a rest rate of 42 puts you in the criteria for severe asthma attack. We don't use blood pressure for any of the criteria in asthma, and Peppa Pig doesn't has got nothing to do with it. So the way I wrote this is that they're gasping for air after completing sentences, so they're still completing sentences. They're just a bit breathlessness after the sentence. The definition for severe asthma attack is not being able to complete sentences. And I know that's really pernickety, but these are the sort of questions that can crop up in finals that can catch you out. So it's always just worth reading the question. Is that all right? Does that make sense? Okay, so nebulizers should be first-line treatment for asthma attacks in hospitals. Yeah, so it comes back to the point where obviously nebulizers, they look great and they make a lot of noise and parents like them a lot, but you should always consider if you can use a spacer first. Nebulizers should only be really used if a child is in like severe respiratory distress and their sats are really low. All right, perfect. I don't know if you're interested in seeing who's won. There you go, Sophie's on it.